I would now request Dr. Nimmi Mulwani to introduce our next presenter. Please, ma'am.
The next speaker we have today is our very own Dr. Ramesh Goyal, sir. He is MBBS, DM, and DNB General Medicine. He works at the Apollo Hospital, and he's an endocrinologist, diabetologist, and today he'll be talking about management of thyroid disorders and diabetes. Over to Dr. Ramesh Goyal, sir. Thank you.
Hello, everybody. At the outset, my sincere thanks to Dr. Mayur Patel and his team for inviting me as a faculty in SwasthyaCON 2021. And in this 15 minutes, I'll be talking about thyroid and comorbid type 2 diabetes. Now, everybody present here will agree with me that both thyroid disorders and type 2 diabetes are rampant in our population. They are very common. So, the focus of my discussion would be that is it a mere coexistence that we see thyroid and type 2 diabetes frequently because of the sheer numbers, or is there any causal relationship between both of them? So I will move with the first slide, and this is a data which I am sharing from Apollo Sugar Clinic. And in Apollo Sugar Clinic, we surveyed around 4,547 diabetic patients with type 2 diabetes across 52 sugar clinics. And the observations were the women with diabetes are at highest risk of thyroid dysfunction. And of this, around 1,200 people, that is 26.5%, had thyroid dysfunction. Around 76.3% of patients with thyroid dysfunction were affected by hypothyroidism. So you can make out that a huge percentage of people with thyroid dysfunction actually had hypothyroidism. We emphasized on compulsory screening for thyroid problem at least once every year in diabetic patients. And we also suggested diabetic women to be more careful since thyroid dysfunction and diabetes affects people when they gain weight or when they are aging. The complications such as impaired metabolic control and cardiovascular risk of unrecognized thyroid dysfunction in diabetic patients were highlighted in this study, and these points need to stand out. And I think this is a under-recognized fact that subclinical or clinical hypothyroidism can increase the cardiovascular risk. So, diabetes mellitus and hypothyroidism, are they strange bedfellows, that is total strangers lying on the same bed, or are they mutual companions? So that is the question mark, and I'm going to answer it in next few minutes. Thyroid disorders and diabetes are two most commonest endocrinopathies, and they frequently coexist. Prevalence of thyroid dysfunction with diabetes is increased than in general population, and overall prevalence is 13.4% of thyroid disease in diabetics. So that is slightly less than our survey, which was around 25%, but yes, it is very common. Highest prevalence is seen in type 1 diabetic females with a prevalence of around 31%, and lowest prevalence is seen in type 2 diabetic males, that is 6.9%. Hashimoto's thyroiditis may be associated with 10% of patients with type 1 diabetes. So this is a huge prevalence. So even if the TSH is normal, actually if we check anti-thyroid peroxidase antibodies in patients with Hashimoto's thyroiditis, we frequently see in 10% of patients there may be antibody positivity for anti-thyroid peroxidase antibody. And approximately 1 out of 4 female patients with type 1 diabetes develop postpartum thyroiditis. So any other autoimmune disease is more frequently seen in patients with type 1 diabetes, which includes the autoimmune thyroid diseases. So this slide shows the prevalence of thyroid disorders in patients with type 2 diabetes. So again, some statistic meta-analysis of all available data in 10,900 plus patients with diabetes revealed a mean frequency of thyroid disease of 11%. So this applies to type 2 diabetic population. Prevalence of hypothyroidism in type 2 diabetic patient is reported from 2.8 to 3.2%. So it depends upon the type of population studied and the cutoffs which are being used but anywhere between 3 to 30% is the prevalence which is recorded in the global literature. Indian data from Manipur reports approximately 28% prevalence of hypothyroidism in type 2 diabetic patients. So again, very high prevalence in the Indian study. So our study showed 25%, Manipur study shows 28% prevalence of thyroid disorders in type 2 diabetes. Now coming on to pathogenesis, that how does hypothyroidism affect a patient with type 2 diabetes? So I will take help of the molecular and biochemical mechanisms to explain this. There are central and peripheral regulation of 5-adenosine monophosphate activated protein kinase AMPK by thyroid hormone. So this is a well established and well documented fact. And here you can see at the level of hypothalamus, under the influence of T3, there is actually a reduction of AMPK levels, and this has various ramifications in the body. So hypothalamic AMPK reduction leads to increase in the activity of the brown adipose tissue, and we all know that brown adipose tissue is very important for the weight management also, and controlling the metabolism of the body. So it is a positive influence on the brown adipose tissue. And how does it benefit an individual? It increases the energy expenditure, and it keeps the body weight in check. So it reduces the body weight. So this is how the thyroid, it acts at the hypothalamic level, and at the tissue level, apart from hypothalamus, reduction in the AMPK levels leads to this positive effects on the metabolism. So in skeletal muscle, there is decreased glucose levels, decreased ectopic fat deposition, increased insulin sensitivity. At the level of the skeletal muscle, again, there is increased glucose uptake, increased lipid oxidation, increased mitochondrial biogenesis. At the pancreatic level, there is decreased insulin secretion, and there is decreased insulin level. So indirectly, these are the markers of reduction in the insulin resistance, which I'll be talking about. There is a decreased circulating lipids, decreased ectopic fat deposition, and increased insulin sensitivity. So this was what I was talking about when I was talking about the pancreas. So there is improvement in the insulin sensitivity under the influence of thyroid hormones, and hence there is a reduction in the insulin secretion and the insulin levels. And at the liver level, there is decreased glucose production, there is decreased lipid synthesis, and there is increased lipid oxidation. So if I summarize this slide, at the tissue levels, the reduction in the AMPK levels induced by thyroid hormones leads to positive impact on the insulin sensitivity and the glucose and the lipid metabolism. So this slide shows the impact of hypothyroidism and how it alters the appetite, the GI mobility, the nutrient absorption, the insulin clearance, and the insulin sensitivity. So hypothyroidism leads to increase in the insulin resistance, and so it leads to hyperglycemia, and it also leads to effect on the other parameters which I already mentioned, and this leads to the tendency towards hypoglycemia. So it's the balance between this factors against the insulin resistance, which determines whether a patient with hypothyroidism will become a diabetic patient or patient with impaired glucose tolerance, or he or she will maintain the normal glucose tolerance. So this slide shows novel clinical evidence of an association between homocysteine and insulin resistance in patients with hypothyroidism or subclinical hypothyroidism. So here we can see in the graph clearly, as compared to control group, in the patients with subclinical hypothyroidism and in patients with overt hypothyroidism, there is increase in HOMA insulin resistance. So as I shared in the previous slide also, that hypothyroidism leads to a state of insulin resistance. Now, what do the various guidelines say regarding the screening strategies and recommendations? So if I talk about the American Thyroid Association guideline for thyroid dysfunction, they say that patients with diabetes may require more frequent testing, and they recommend TSH from 35 years and every 5 years thereafter in all adults with type 2 diabetes. Similarly, ACE in 2015, they said that subjects at risk for diabetics should be screened every 3 years. However, patients presenting with 2 or more risk factors can go for annual screening. ACE recommends thyroid palpation and TSH estimation at the time of diagnosis as well as after regular intervals in type 2 diabetic patient. And in case of goiter or other autoimmune diseases, it becomes more essential to get these estimations done. And they are not specifically mentioned the exact time duration. The ADA in 2017 says that there should be frequent screening of patients with diabetes. And they also say that thyroid palpation in type 2 diabetic patient and TSH in adults more than 50 years is must. And it is also must in patients with dyslipidemia. So this is how the various guidelines goes. Do the therapies complement each other? So this slide shows that treatment with levothyroxine reduces the A1c in patients with type 2 diabetes coexisting with subclinical hypothyroidism. So thus the dark bar you can see the patients were treated with levothyroxine, and the light bar you can see they were not treated with the levothyroxine, and there was a difference in A1c in favor of the group which received the levothyroxine treatment. And on the other hand, treatment with metformin plus levothyroxine reduces the TSH level significantly than metformin alone in patients with type 2 diabetes. So if you treat a patient with subclinical hypothyroidism and type 2 diabetes with metformin plus levothyroxine, then there is better reduction in the TSH levels as compared to patients who are treated with metformin alone. Now, there is a publication which states that TSH lowering effect of metformin is seen in patients with type 2 diabetes. So, in this study, after 1 year of metformin therapy, a significant decrease was observed in diabetic patients with hypothyroidism who were either treated or untreated with levothyroxine, but not in 54 euthyroid patients. So, if you treat the patient with levothyroxine, the TSH levels go down better as compared to patients who are euthyroid and who are not treated with levothyroxine. There was no significant change in free T4 observed in any group, and on top of it, a 30% shrinkage of initial nodule size when metformin was administered alone, and about 55% when it was added with the levothyroxine. So metformin definitely has some effect in reducing the HbA1c, which is synergistic with the levothyroxine. So metformin reduces thyrotropin levels in obese diabetic women with primary hypothyroidism or on levothyroxine replacement therapy. And there is another publication, metformin and low levels of thyroid stimulating hormone in patients with type 2 diabetes. And there is another publication which says that metformin inhibits the goiterogenesis effect of type 2 diabetes. So plenty of literature supporting metformin on the levels of TSH as well as the goiter. With this, I would like to end my presentation. Thank you everybody for your kind attention, and I'll be glad to join the panel discussion during the question answer session. Thank you very much.
Thank you, Dr. Ramesh Goyal.